Hello, welcome all. Coming on to the Retrograde CTO Academy again. Today, I will be discussing about a technique that is called as intracoronary CTO body tip-in. There is rendezvous technique, there is tip-in technique, and one is the thing that is called as intracoronary tip-in. Many times when the retrograde microcatheter cannot be brought into the antegrade guide, maybe due to calcium or long segment, then many times this tipping technique helps. So coming on to this particular case-based discussion, I would be discussing how this tipping technique helped in doing the PCI of RCS CTO by retrograde approach. So, just to brief, what is actually intracoronary dip-in technique? So, there would be some cases where the microcatheter from the retrograde wire cannot be traversed across the CTO, maybe due to calcium or longer segments. Then this retrograde microcatheter cannot be traversed to the antegrade guide. So, what can be done? Many times, this wire from the this retrograde microcatheter is introduced into the guide if possible, and over that a microcatheter inside the guide is kept, and across the curvature or greater curvature of the guide this wires enters the tip of the microcatheter in the integrate guide, and this is called as tip-in, integrate tip-in. But many times even that is not possible. So what can we do? It is a partial modification of the rendezvous technique. In rendezvous technique, what we do, we bring the microcatheter together, and from antegrade microcatheter, we try to negotiate the wire into the retrograde distal microcatheter. This is called as typical rendezvous technique. But even if that is not possible, then this is a partial modification that within the coronary CTO segment, if we are able to get through this microcatheter, and this tip of the microcatheter is just coming into the lumen, then the antegrade wire can be negotiated into this microcatheter, and then this distal microcatheter can be withdrawn and the PCI can be done. So the clinical summary of the case: 65-year-old male hypertensive non-diabetic patient, a case of a old and stable angina. He had undergone a PCI to LAD and circumflex in June 2021, and it was done at a different center. And the patient RCA was ostial CTO, and it was tried but failed. So, seeing this was the angiogram when the patient reported to us. So this is RCA CTO, and we can say the stent in the LAD, and this LAD is giving very good CC2 collaterals to the PD, and this appears to be a long CTO segment, and it is a ostial CTO, and it is a tried CTO. So, as per the algorithm, it can be taken as a primary retrograde strategy in this setting. So this was planned, and femoral access was taken for the EBU, and this was hooked, and this angiogram was taken, and the left system reveals this uh, microcatheter, this microchannels, that is the retrograde. This collaterals can be seen from the left to the right. So this is the AP view. So 132 collateral are good, can be seen. So we went ahead with the primary retrograde strategy. We took a Carabel microcatheter, and over that we took a Sion wire. And after a few negotiation, after septal surfing, we can say that we took the good septal, and it was after taking a bend at the this junction of the collateral and the PD. It took a bend, and the wire could be negotiated into the distal RCA. And gradually, this microcatheter was cautiously advanced into the distal RCA to the mid RCA. But the problem with this, we can see that due to calcium, this microcatheter is not going ahead. So many times this is a common problem, especially in Asian population, where the CTO are not only complex, but as well as they have a calcium component more as compared to the Western population. So exteriorization many times becomes a problem. So in this particular case, different wires were tried, even the GAA2 were used, but Actually, it was not going to the proximal segment. And what we assessed, the one thing different also seen from the antegrade injection, we can see that the wire from the retrograde appears to be in a different course. It was mainly a pseudo ostia. What we see, the thing that is hooked is actually it's showing two ostia. So one is I think a blunt stump, and other is maybe a branch. So it was a pseudo ostia. So in this particular course that was suggested by the retrograde wire, over the Ruri wire, we took another filter XT wire so that we can keep the distal wire as a marker. So fortunately, we were able to negotiate the distal microcatheter up to the, I think, proximal part of the lumen of the CTO, and we tried to negotiate the tip of this wire across the retrograde microcatheter tip. So it is an intracoronary, what we can say, partial modification of the Rondeau technique, because the proximal ostial segment was short and microcatheter was not, integrated microcatheter could not be crossed till the proximal segment due to lack of support from the guide. So we just took a balloon support and we tried to negotiate this wire into the tip of the distal microcatheter. Unfortunately, it crossed that micro tip of the microcatheter, and over this we took the wire inside the microcatheter, and after that we can see this heart in heart image. That means we are through and through from antegrade to the this CTO body to the distal true lumen. And now we just negotiated, we downgraded the wire and pulled the distal microcatheter a bit into the distal RCA across the collaterals, and wire was downgraded to run through wire, which reveals ostial to distal RCA long disease. So now, in meantime, we also saw some disease distal to the LAD. So even distal LAD was fixed in the meantime, and for RCA, body wire was used for the support, and after that, routine PCI was done, and this three discs were implanted in the RCA, and overall, we can say a very good result was seen. So this particular case highlights the importance of the CTO segment, which are uncrossable with the microcatheters, and many times due to calcium, it can be a problem. So this Rondeau technique or tip-in technique or intracoronary tip-in technique are very useful techniques if can be done. In this, we need not to bring the microcatheter, retrograde microcatheter into the antegrade guide. We can just push the wire if it is going into the antegrade guide, and if we are able to cross microcatheter placed in the greater curvature of the guide, then it is called as tip-in, antegrade guide tip-in. But if it is not going, then we can bring the antegrade microcatheter till the CTO body and the retrograde microcatheter just front to each other, and we can cross wire from the antegrade to the retrograde microcatheter. This is called as Rondeau technique. And even if this fails, then we can put the distal microcatheter tip into the, if it is coming into the proximal true lumen across while traversing the CTO, and if this microcatheter is not coming into the antegrade guide, then we can negotiate the antegrade wire to cross this microcatheter tip. Although it is many times difficult, but can be useful and promising many times. So good understanding of what is actually tip-in or reverse tip-in or intracoronary tip-in or Rondeau technique is needed for the success, and especially in calcified CTO when we are going with the retrograde approach. So this was all about the tip-in and the Rondeau technique. So thank you all for patient listening, and we would be coming into the next session. I would be discussing how to go retrograde CTO by epicardial collaterals. Thank you.